When I see a new patient for the first time, with cancer, I don't talk about death when I see a patient for the first time. I have to develop the relationship. I have to develop the relationship with the patient and the family, that together, let's make decisions which are in the best interest of the patient, and the patient must lead that discussion. We have to be sensitive about when to bring it up and how to bring it up. Okay, so yesterday afternoon, I've got a 94-year-old patient who I have treated 3 cancers. She's a lovely person. I've treated her through 3 different cancers, and I suspect that, one of her tests became abnormal. Well, my first question to her is, do you still want to come and see me? Because, you're 94. Coming to see me is a big effort. Although she's independent of our activities of daily living, just coming to see me and sometimes having to wait up to an hour to see me. I asked her, do you want to keep these appointments, or do you just want to make it anytime you have a problem, I'll see you? She says, no, I want to keep to these scheduled appointments. So I said, fine. Then I asked her, do you still want me to run any tests on you? Because if we run tests and the tests are abnormal, and if you feel fine, what are we going to do? And she says, no, I still want you to continue doing tests because you've been doing it for 20 years. I've been looking after her for about 25 years. And I still want you to continue doing, the tests. But we've agreed we're not going to scan anymore. But, she wants to do her blood tests. So I said, okay, we'll do her blood tests. And so I saw her on Monday, and one of her tests was abnormal. And the test suggested that she may be bleeding internally. And her previous cancers, all 3 of her previous cancers were all in, one was in the stomach, 2 were in the colon. So there's a chance that she may have a new cancer either in the stomach or in the colon. And so, I shared it with the family. And so I said, well, we've got this test. What do you want to do? And the patient said, well, I want to go for a scope. And the family now are very concerned. You're 94. Can you tolerate a scope at 94? So they're asking me, what do I, what's my recommendation? So I said, well, firstly, it's the patient's choice. The patient should decide whether the patient wants a scope or not, because if she has, let's say she's developed a new cancer, well, even at 94, we have to figure out what's the best way to treat that cancer in a way which preserves this patient's quality of life, and allows the patient to be in charge. Because there's a chance that the cancer may be in an early stage, and there's a chance that we may be able to do keyhole surgery, and there's a chance that the patient may be able to, to get through this. I mean, my mother was 86 when we discovered she had colon cancer, and at 86, my mother had her keyhole surgery and was discharged after 48 hours, and my mother's now 96. So I don't use age as a decision as to whether we treat. Of course, we have to be very cognizant that complication rates are higher, but ultimately it's a decision between the patient, the family, and the team. What's the safest, and what is the decision which would optimize the patient's quality of life for as long as possible? There's no one decision or one size fits all. It's a conversation, but the key is that there must be a relationship. Death is part of life. I think unexpected death, I mean, you could say that, okay, that's a failure. So yes, we will all die. We just don't want to die from something which is preventable, or we don't want to die unexpectedly. Certainly, if someone's death is preventable, then that is a failure. So we need to ask ourselves what failed. If something is unexpected, we should ask ourselves again why. Did we miss something? And when I say we, it's not just the healthcare system, it's with the family. It's the whole network to really say, what happened and how could we have anticipated it? How could we have prevented it? But, if death is expected and if death is not preventable, then I don't think that's a failure. In fact, we should celebrate a life well lived. We should celebrate a life well lived. And, I always say that, personally, I don't think that the person has physically gone, but that person is still deeply remembered by loved one and friends, just in a different dimension. I realize it's my responsibility to make sure that my patients have a good death. I'm so grateful for all my colleagues and the system that's evolved in Singapore. I still remember when I came back in 1992, Cynthia and Rosalie were starting. I was very actively involved in the hospice movement when I came back. I think in Singapore, the cancer patients have a much better death now than they did 30 years ago. But I really hope that this cuts across now all disciplines. Usually, hospice movements start out of cancer, but it should cut across every chronic disease: stroke patients, heart attack patients, renal failure patients, even severe pneumonia. COVID patients who cannot be weaned off a respirator or have severe illness. Yeah, I think we should have that because it's very traumatic to everyone. I think palliative care is just, again, part of it's critical. It's part of our whole journey. You've got preventive care. We do everything to try and prevent people from developing things which are preventable. Person-centered integrated care. So my patients with cancer, so many of them have high cholesterol, they've got diabetes, they've got high blood pressure, some of them have got coronary artery disease, a few of them have had their strokes. Again, I help manage them with my colleagues through that. And then you've got end-of-life care. As soon as we know the patient's got a cancer that's incurable, I ask palliative care to be involved. Even though, I've got some patients where they've got an incurable disease, but they're doing well, and it's been more than 1 year. But palliative care has been involved at the start. They sort of see the patient every 3 months or so. But as the patient's care deteriorates, they start seeing the patient with me more and more frequently. Very good studies have shown that the quality of life and even life expectancy is better when palliative care is involved early rather than late. Sometimes when patients with advanced disease, but they have no symptoms, but the scans show that the disease is advanced, and I know the chances of a cure are not good, and I tell them I want to involve my colleagues from palliative care. They sort of look, quite taken aback. They say, well, I feel fine. And I say, yeah, that's the whole goal, is for you to continue to feel fine for as long as possible. Because palliative care doctors are experts in symptom management. I try and keep on top on all the advances in terms of symptom management, but it's like cooking. I still cook by cookbook. My wife cooks by feel and touch, and she laughs when she sees me following a recipe. So, I look at palliative care. I still, in a way, follow the recipe. The palliative care it's experience, touch, and feel, and they know how to titrate both medication as well as non-pharmacological interventions in terms of optimizing quality of life. So they're a tremendous ally and part of the whole multidisciplinary team. So I think they're critical. I think they're a wonderful group of health professionals, doctors, nurses, social workers, all involved in ensuring that end of life is a good death. I think my earliest experience with death was when I was probably 8, 9 years old when my grandfather passed away. My grandfather passed away relatively unexpectedly. I mean, he had been ill for some time, but I still remember the phone call early in the morning to my parents, and my parents waking us all up and going to my grandfather's house and seeing his corpse. That was it's still in bed, and that was probably my first real experience with death. In terms of impact, I've had both good experiences and very painful experiences. In terms of painful experiences, was when I was a young doctor and seeing patients die in hospital, and it was very traumatic. If the death was uncomfortable, I could see that the patients were very distressed, and if there were family members there, it was just as distressing also. So the whole level of distress between patient, family, and the care team, doctors, nurses, it was very traumatic. So I saw this as a junior doctor. And then as I progressed through my training, I was lucky that I was able to be trained both in Singapore as well as overseas. And I spent 7 years in New York. They had teams there managing death in a way that was not as traumatic. Now, when I left Singapore to go for training in the States, it was a very different Singapore at that time. Firstly, they would anticipate who was going to die. In the 1980s, the law was coming in America where you had to discuss resuscitation status with your patient. I mean, everyone had to have their resuscitation status declared in the case notes. I was pretty shocked. I mean, we never talked about resuscitation status in the 1980s when patients became admitted. Even now, I know of many instances where the resuscitation status is not discussed outside of my discipline. I mean, in cancer, we really do have that discussion. And the way we approach it now is we tell our junior colleagues, and we tell our students, would you be surprised if this patient is not alive in the next 6 months? Would the family be surprised? Because if the family and if the patient and if you as the professional team would not be surprised if this person was not alive in the next 6 months, we need to start talking about what's going to happen in the next 6 months. How does the patient want to live the next 6 months? What are their goals? And we need to have this discussion while everything is stable, because you definitely do not want to have this discussion when the patient is in extremis. When I share with medical students that when I started work in 1981, we were recycling needles, and there was no such thing as an intravenous drip set. You would use a steel needle. And when you recycle needles, every night you could hear this humming noise from our hospitals. They were sharpening the needles for the next day. And they were blunt, and it was terrible. So in 1981, as a junior doctor, I used to buy my own needles. I used to go to Outram Park, buy my own needles, buy my own drips, intravenous drip sets. And I guess the junior doctors now just can't believe that Singapore in 1981 was so resource challenged. In 1981, Singapore was still a young country. We didn't talk about good deaths. In 1981, many of our patients coming in were either trauma patients or or infection. Yeah, we saw some heart attacks, but not as much as now. We saw strokes, but the bulk of the cases we used to see used to be infection and trauma. 1981 Singapore, if you told me that Zouk was going to be where it was, I would say you got to be out of your mind. When you drive down River Valley Road, you could smell the Singapore River before you even came anywhere near it. And that whole area where Zouk used to be and where Grand Copthorne, that was snake infested, and it was terrible. It was vile. It was a very different Singapore. When we move from a very young society to a rapidly, we're going to be a super aged society probably in the next 3 or 4 years. And again, the speed at which Singapore is undergoing a transformation in its demographics has never been experienced by countries in history. The fact that you can double the number of people over the age of 60 or 65 within 15 to 20 years, that's unprecedented. No society has gone through that before. I mean, Japan went through it, and Singapore's aging even faster than Japan. Japan took 24 years to double the number of people aged over 65. Singapore is going to do it in 17 years. That's how fast Singapore is aging. The two things that are happening in Singapore is that now for the first time in history, there are now more people in Singapore aged over 60 than under 5. You can say the good news is that since independence, so in the last 57 years, Singaporeans have increased lifespan by 20 years. In 1965, when we became independent, lifespan was 65. Now lifespan is 85. So we've added 20 years of life. So that's the good news. Our total fertility rate has dropped from 3 to 1. So we've gone from a young society to a super age society within my lifetime. Median age in Singapore now is 43. I would probably say in the next 10 years, many people in this room are going to be close to 40 or 50. And how do we want to live, the next 30 years? And of course, when you start thinking about older age, we need to start talking about death. Death is part of life. We want to be able to have a full and rich and purposeful life where we can be and do what we value, all the way to the end. And then when the end comes, we all want to have a good death. And a good death as how we would be as the person dying, as well as our loved ones who watch us die. Because if we are distressed, certainly our loved ones will be just as distressed. So how do we make sure that we start and finish and the whole journey, how do we do it as optimally as possible? Are we going to expect the Americans to come and teach us how to do it, or the Chinese, or the Australians, or the Japanese, or the Germans? No, we have to decide for ourselves. And I mean, we are now one of the most educated societies, in the world. We have the resources too. So this should be a whole of society discussion. How do we want to live an 85, 90, and soon 100-year life? Okay, so half the primary school children in Singapore are going to live to 100. So how do we want to live a 100-year life? A good life. And then how do we want to have a good death? Unfortunately, Singaporeans are not a very healthy population. And that's one thing we really want to try and shine a spotlight on and say, hey, Singapore, we are not as healthy as a population as we should be and as we could be. I really recommend every Singaporean to read the National Population Health Survey. Comes out every 2 years or so. So the last one was in 2020. You can download it. When you read about the health of Singaporeans, it's not good. 3/4 of Singaporeans over the age of 70 have high blood pressure. 3/4. And of that 3/4, I think 2/3, the blood pressure is not well controlled. And we know that if you don't have well-controlled blood pressure, your risk of dementia goes up. Of course, your risk of heart attacks and kidney failure go up. But dementia is a huge challenge when you've got both to the person as well as to the entire family and the whole ecosystem. I think every family now is seeing chronic disease in the family. There's usually someone in the family who's got high blood pressure, who's got diabetes, who's had cancer. I think probably every family knows someone with cancer. And so again, when we start facing this issue of chronic disease and both morbidity as well as mortality, these conversations will happen. And I think we should talk about it. We need to start, everyone in this room should have this conversation, as families. In terms of research in medicine and sciences, that's been going on in the university. The medical school has been around since 1905. So let me start off by saying I'm not a pioneer in life sciences. I was involved in persuading the government that we should really invest in health and biomedical sciences, and between 1997 and 1999, over those 2 years, we were fortunate that the government was willing to do so, and we are where we are now. It's all part of being in an ecosystem which wants to always ask ourselves, how can we do this better? Again, cancer was quite stark. We had been treating lung cancer the wrong way all the way until probably 2004, because we were treating lung cancer through textbooks, and the textbooks were largely written in the United States and United Kingdom. And the lung cancer that they see is a different lung cancer than the lung cancer that we see. It's a cancer involving the lungs, but the biology is different, the treatment is different, the cause is different. When I came back from the United States in 1992, that was one of the first things that struck me. I credit the Americans for training me well. So I came back confident that I knew what I knew, and I also knew what I didn't know. And one of the first things that I started seeing when I was treating as a cancer specialist in 1992 was that, hey, the lung cancer we're seeing here is not the lung cancer I saw in New York. And so I started asking around the region, and colleagues in Hong Kong and Taiwan said the same thing. The lung cancer we see here very often involves women, non-smokers, and they're in their 40s. Why should non-smoking women start coming down with lung cancer? And the theory in the 1990s, which Hong Kong proposed, was that because it's from the inhaling the fumes from wok cooking. You have a superheated wok, and you wok hay, and you inhale the fumes in an apartment that's not so well ventilated, leads to lung cancer. So it sounded very plausible. But then I was looking at my patients, and many of my patients, number one, didn't cook. They would be professionals working, and they would have a domestic helper cooking. And our HDB apartments are very well ventilated, So I said that can't be the only reason. I was fortunate that the Australians were very curious, and so Jim Bishop, who was formerly head of medical oncology at the Peter MacCallum Cancer Institute, then went to Sydney to become the director of the University of Sydney Cancer Centre. Jim and I decided to do a study of lung cancer Singaporeans versus Australians. The Australians would supply the Caucasian population, and the Caucasians usually would be men with smoking with lung cancer, and Singapore would supply the Singapore population, which was very often Chinese women with lung cancer. And we did this study, and the study showed that, yes, we were seeing differences in response to treatment. When I presented these findings in Boston in 1996, 1997, a lady in the audience got up and said, you're a racist. How can you profile patients whether they're, Chinese or Caucasian, And so I said, look, I'm not a racist. I'm just trying to say that this is what the data is sharing with us, that this is a different disease. Response to treatment is different. Then we were lucky. AstraZeneca was developing a tablet to treat lung cancer, which in animal models was showing that this was a very exciting tablet. You take one tablet a day. It was not causing all the side effects of classical chemotherapy. And so it just happened that from 1992 to 1997, we had built up our ability to do experimental clinical trials. So we were a trial site with the AstraZeneca drug. And when the data started unfolding, we were seeing spectacular responses. We were seeing up to 70%, 70, of our patients having shrinkage of their lung cancer, sometimes complete disappearance. In America, they were only seeing 5%. In fact, the results were so dismal in America that AstraZeneca was not going to proceed with developing the drug. Now, it just happened that Singapore was reporting, Taiwan was reporting, Hong Kong was reporting, Japan was reporting that we were seeing very high rates of response. And then long and short of it, the people in Harvard and Boston showed that the lung cancer in East Asia, very high degree, 70, 80%, we have, for some unclear reason, a mutation in a specific receptor that allowed the drug to really bind tightly, while in the West, most of them did not have this mutation, so the drug would not bind. And overnight, it changed the treatment of lung cancer. From the time I was a medical student until 2004, we were treating lung cancer the wrong way, because we were treating lung cancer according to the type of lung cancer seen in the West, while the lung cancer seen here is a different type of lung cancer. So my message to people is that, number one, we should all be confident in our training, and when we see something that's different, we should ask ourselves, what is this telling us? And how do we do the research to understand what is the best form of treatment and management for our population? And many times it's the same, but there are enough examples in everything from stroke to heart attacks to obesity to cancer. When SARS hits Singapore, what we see is a different type of what we call phenotype. What we see in patients amongst the Chinese, Malay, Indians can be very different from what we see in a Caucasian population. So we do need to invest in our own ability to ask questions and to answer questions which are relevant to our society. Yes, we should definitely learn from around the world, but we should remember that we stay in a different environment. Our genetic makeup is different. The classic example is alcohol. Many Chinese cannot take alcohol to the same degree as Caucasians. The Indian population may be able to metabolize alcohol better, but the Chinese very often lack the ability to metabolize alcohol, so Chinese flush very easily, can get intoxicated on a relatively small amount of alcohol. Now, we all sort of laugh at alcohol, but can you imagine when it happens to medication? And there are multiple examples of medication where the dosage is different between different genetic backgrounds. Singapore must decide, how do we want to live, learn, work, and play? What kind of life do we want for ourselves, for our children, for our grandchildren, as they live long lives, up to 100 years, maybe even more than 100 years for our grandchildren, I don't know. But certainly now it looks as if the children in Singapore are going to live to 100. So how do we want a full and rich life where we've got opportunities throughout the lifespan? we should make this a living conversation so that ultimately it's our social compact. What's the social compact that we want in Singapore? And that social compact should have equity and should have cohesion. Well, I mean, one of the biggest challenges in Singapore is ageism. It's not unique to Singapore, it's a global phenomenon. Ageism is so unique. It's the only bias, it's the only discrimination that individuals have against their future self. If you think about it, if people have this concept that older people should be very different from younger people, well, everyone who's young is going to become future old. So it's a bias against one's future self. And really trying to say, no, we should really look at a life course. Currently, I'm concerned that many people think they've got opportunities until 60. So what happens between 60 and 90? How can we harness the tremendous knowledge and wisdom and potential of people throughout their entire lifespan? So I'm very keen to see how we can get people between 60 to 90 to say, how can you still be, you know so much, you can contribute so much. I want to reach out to them and say, please be as engaged. You're extremely valued. Because when we speak to residents of Queenstown, many of them say that they no longer feel valued. So how does everyone feel valued in society? Minister Tan See Leng in Parliament said there are 260,000 women between the ages of I think 25 to 64 who are not in the workforce. So if those 260,000 women are not in the workforce, how are they going to have financial security when they're in their 70s, 80s, and 90s? Because if they have no CPF, how do we ensure financial security for all Singaporeans if there are 260,000 women? Because women live longer than men. They may not be in the workforce because very often they're carrying an inordinate amount of childcare and parent care burden. So how can we make childcare and parent care far more equitable so that women have the same opportunities as men? So these are whole fundamental questions we have to ask society. Okay, so I'm 65, and I hope to stay in the workforce because I still think that I can contribute. And I think there are many other Singaporeans who can contribute. So how do we give opportunities for people to continue contributing? There's this big chunk of Singaporeans who are not engaged, and I would really like to get everyone to continue because it's a whole life course. Life does not end at 60.